Hello, welcome to this AATS Roundtable discussion entitled Characteristics of Robust and Trustworthy Coronary Guidelines. We have a panel gathered here. We're missing one person who's stuck in extreme situation because of what's happening on the streets in Toronto, and he will be joining us later. I'm Faisal Bakaeen. I'm a cardiac surgeon at the Cleveland Clinic, and I would let the team members of this panel introduce themselves.
Hi, I'm Jospeh. I'm a cardiac surgeon, chair of surgery at University Hospitals, Case Western Reserve University.
Hi, I'm Patrick Myers. I'm a cardiac surgeon from Switzerland in Lausanne.
Hi, I'm Dawn Huey. I'm a professor of cardiac surgery at University of Texas, San Antonio.
And we're missing Dr. Milan Milojevic, who, as I said, will be here shortly. Now, recently there has been controversy raised about results and conclusions of some trials and issues raised about the trustworthiness of the guidelines. Now, today we're going to address those issues as they pertain to coronary artery bypass grafting. We will bring you up to date on important developments and what steps have been taken by our associations to address those challenges. Perhaps I could start with Dr. Sabik by asking about what happened back in 2021 with the ACC-AHA SKY Coronary Revascularization guidelines.
Well, thank you, Faisal. I think the most important thing is, as you know, the surgical societies, both the Society of Thoracic Surgery and the American Association for Thoracic Surgery, decided not to endorse the guidelines. And that really had to do with the downgrading of the class of recommendation for coronary surgery versus medical therapy to improve survival in patients with multivessel disease. Coronary surgery was downgraded from a class of recommendation 1 to a class of recommendation 2B. And that's the same recommendation that PCI is given in multivessel disease. And I think it really has to do with a few things. One thing, deciding not to take into consideration studies and trials that had been taken into consideration in past guidelines, and then also over-interpretation of present studies. You know, as you know, there were studies done many years ago looking at medical therapy versus coronary surgery in patients with ischemic heart disease. And what those studies found was that in patients with large ischemic burdens, those with left main disease, triple vessel disease, single or double vessel disease that included the LAD, that coronary surgery improved survival, but also improved quality of life, decreased late myocardial infarctions, and decreased the recurrence of angina. All of that data is old, and it was decided to be disregarded, mostly because medical therapy has advanced. But as we know, medical therapy not only helps patients who haven't had revascularization, but also helps patients who've had revascularization. So there's no reason to think the effects of medical therapy will be any less, but at least equal in patients who've had surgery. But the committee also decided not to consider recent evidence. You know, the strongest evidence supporting coronary surgery in patients with multivessel disease is really the Syntex trial. You know, as you know, this was a study comparing PCI and CABG in patients with both multivessel and in left main. And if we look at patients with multivessel disease, CABG not only improved survival, but also improved quality of life by decreasing angina, decreased late myocardial infarctions, and decreased the need for repeat revascularization. So the only way that coronary surgery cannot be better than medical therapy is if PCI is worse than medical therapy. And we know that not to be true. We know that in patients with stable ischemic heart disease, PCI and medical therapy are equal by multiple randomized trials. But for some reason, they decided not to, include that data. I think the real problem was with the overinterpretation of the ischemia trial. Now, ischemia is a fantastic trial, no doubt about it. But we really need to understand what it was. It was a trial that compared initial conservative therapy to initial invasive therapy, not CABG to medical therapy or PCI to medical therapy. However, it was applied to that situation. And if we even look in the invasive group, those that were in the invasive group, I think only about a fifth got CABG. So how can we say anything about coronary surgery when such a minority of patients actually received it in the trial? So I think as we look at this and what do we learn, we really need to think about the process that we have and to make sure the process is fair and that studies that are important are included, but we cannot also overinterpret studies.
These are all excellent points, Joe. We've discussed them back and forth, and it seemed like we thought that our cardiology colleagues, their associations, were going to correct course. And for the 2023 ACC/AHA chronic coronary disease guidelines, that we will be able to relook at the evidence and come up with recommendations that are based on the best available evidence, taking into consideration all the excellent points that you've raised. However, this unfortunately didn't happen. And that is why the two surgeons who were representing the STS and the AATS, with discussions among the leadership of the AATS and the STS, decided to pull out of those guidelines, which is really unfortunate because our goal has always been to collaborate with our cardiology colleagues and to stick to very objective evidence and build those recommendations on the best available evidence. We believe in a robust process, a fair process, an unbiased process. Now, talking about collaboration, our European colleagues, the surgeons, have an interesting experience. Patrick, you were able to recently collaborate closely with the cardiology colleagues in Europe, and in view of the new available evidence, you were able to update and revise the left main guidelines. Could you please shed some light on this important achievement?
Oh, thank you very much. That's actually a very good segue from what Joe was just talking about, of process. That having a clear process set out on how you develop these guidelines was very important, that we had a memorandum of understanding between our two associations before starting off, setting the stage, saying equal representation of cardiologists, surgeons within the task force. And with that, we're able to review the latest evidence. And that was based essentially on the Sabik and colleagues' meta-analysis published in The Lancet, which clearly showed there was no benefit in terms of mortality for CABG versus PCI and left main disease. However, and that's what shows how it's so important to have all of the secondary outcomes published using good scientific publishing and research practices, is that the supplementary table showed clearly that there was a benefit in terms of MACE for CABG. And based on that, the task force came to the conclusion that PCI should be downgraded. It was a 1A recommendation for PCI in low complexity syntax score, left main disease, and it was downgraded to 2A, while CABG remained a 1A recommendation. And it's really quite satisfying to see that we could, in our daily practice, my closest friends and colleagues, our interventional cardiologists, we're all aiming to bring the best to our patients. We see the evidence differently, but when we set things up so that we can discuss the evidence in a fair and balanced way, and so that everybody can have a voice, it makes it so that we can reach conclusions which I think are really quite admirable.
I mean, again, congratulations. That was quite an achievement because you really let the evidence guide you, and you base those recommendations on your best interpretation of the available evidence, and you were able to make those changes. Now, when we go back to the process, I mean, we as surgeons need to have our house in order before we look at others and say, hey, we should do it this way or that way when it comes to guidelines. Now, Milan, our societies, both cardiac and thoracic, from North America and Europe, got together, and the intention was to harmonize the guidelines and to come up with a roadmap for how in the future we're going to come up with trustworthy and robust guidelines. Can you please tell us more about that?
Yeah. Then thank you for your question.
And I'm glad you could make it,
yeah,
because that looks really bad outside from what we heard.
I'm so sorry about it, but so I think that the term harmonization in our title really speaks the volume about our initiative to harmonize not only the methodology that already exists for development of clinical practice guidelines in Europe and the USA, but also to harmonize them with the Institute of Medicine and their pillars and recommendation in order to let's say to make a better methodology manual for all our members, to try to improve the transparency, the scientific rigor, try to minimize the biases that exist in all the guidelines, and really provide the robust evidence-based recommendations. So I think it's a unique in a way that it's the first transatlantic joint methodology for clinical practice guidelines, and that we really try to include the best guidance from the regulatory bodies in order to more of them, when we start producing these guidelines, they can take it, look at it, and endorse it as official documents for policy making.
Yeah, we kind of gave a presentation earlier today about this methodology, comprehensive methodology manual, and it was very well received. And hopefully it'll be in print soon, and our members will be able to read and learn more about it. So thank you for all the efforts that you put into this. Very much appreciated.
Thank you.
You know, what this will serve as is a roadmap for further guidelines and collaborations with our cardiology colleagues and oncologists, etc. And I think that's an important step forward. Now, if we take a step backward and look at the raw evidence, basically the trials and the studies that provide the raw evidence on which those guidelines are based, I have some concerns. I mean, recent trials or studies, the sub-studies of them or meta-analysis of a collection of them look a little dubious to me. You know, the design and the analysis plan are sometimes not perfect. I mean, nobody's perfect, but the definition tend to be loose. They tend to change over time, and that could introduce some perhaps errors into their interpretation, because many of them are hypothesis generation as sub-studies or meta-analysis or post hocs, but yet somehow their findings get published in higher impact journals, and suddenly they become evidence when they're published in higher impact journals. So us as surgeons need to be aware of those dangers, need to be aware of those potential problems. And I'm just going to give some examples. The Bangalore meta-analysis is one of the references used in the 2021 revascularization guidelines. And in it, ischemia was the largest study. But if you really look at the trials that were included, half of them did not have a CABG arm. That is remarkable. And in those that had CABG, 16% of the revascularization procedures were actually CABG. The rest, the majority, were PCI. So how could you use that to inform the downgrade of CABG from class 1, as Joe mentioned, to class 2B? Another example is the ischemia post hoc analysis about completeness of revascularization, which was at 36%. I mean, that's lower than it's ever been reported in any other study, including Syntax. It's nearly half, just over half of what was reported in Syntax. That is really implausible and really raises red flags about the veracity of the data and the definitions used in this post hoc analysis. And also in ischemia, you mentioned, Joe, I mean, not a single patient was randomized to CABG, but if you look at the substrate of patients, only 36% had a proximal LAD lesion that is greater than 50%. I can't remember the last time I operated on a patient without a significant proximal LAD lesion. Talking about ischemia, another post hoc analysis was comparing medical therapy to PCI to CABG and perioperative MI, which, by the way, did not correlate with hard clinical outcomes, was included in the MACE composite. This spuriously raised the rate of MACE in CABG, thus disadvantaging CABG relative to PCI and medical therapy. While if we look at a post hoc of FAME3, actually I shouldn't say post hoc, but the 3-year results of the FAME3 that were recently published, they somehow dropped the repeat revascularization, which was part of the primary endpoint, because that MACE included repeat revascularization, to somehow, when they report the 3-year outcomes, show that the p-value was insignificant. But if you look at the intended composite outcome that was a primary endpoint, which included repeat revascularization, it was heavily in favor of CABG. So that tells you how you can play around with things to favor one modality of therapy over another, when we all know that we should really stick to protocols and be very strict about the robustness of the protocol and adherence to the protocol. Otherwise, we should all raise questions. So I'm going to switch gear a little bit and mention something to Don, because you and I have been talking about this. Some trialists, both surgeons, I mean, mostly actually cardiologists, but some surgeons argue that MACE may not be a good primary endpoint, and that they suggested alternatives that have not been validated as a replacement. How do you respond to that? What's your opinion?
Yeah, that's a great point, Faisal. So, I mean, to eliminate MACE as a primary outcome is really to discount two fundamental principles of coronary disease. Number one, that it's a chronic and progressive disease, and number two, that revascularization benefits patients by mitigating that disease process through reducing future cardiovascular events and prolonging mortality. And MACE is an incredibly well-validated endpoint to capture those outcomes, to capture the disease process, and to capture treatment effects. So it really should remain a primary outcome in any study that's going to examine revascularization. I think the other aspect is that, as Dr. Sabik mentioned, there have been improvements in all aspects of cardiovascular care. We see that already captured in revascularization trials with improving stent technology and hemodynamic guidance of lesion selection for treatment. But maybe what's not as publicized is that there are, a number of advancements in CABG care. So, for example, minimally invasive approaches, better use of multi-arterial grafting, and enhanced recovery. And those will impact outcomes such as prolonged ventilation, blood utilization, AKI, which we know are also tied to long-term outcomes. And so, it's really premature to say that we should abandon MACE, or that we know everything about MACE for PCI versus CABG in the existing trials, because they haven't always used contemporary practices. The other thing about MACE is that there are no trial-level data for certain demographics, and that's important. To replace MACE with quality of life is an interesting concept. Certainly, quality of life is an important aspect of care and decision-making for patients and their families. But quality of life should be contemporary to and not replacement of MACE. Patients want to know whether they will live better lives, but they also want to know for how long that will be happening. And post-hoc studies or post-hoc analyses of existing trials show that there is a crossover at some time point between PCI and CABG when it comes to that quality of life benefit. So I think that quality of life studies going forward should not be limited to 2 or 3 years, but really should follow patients out, I would say, to a minimum of 5 years. And since we are talking about prolongation of life as a benefit of any revascularization, ideally 10 years or more. And finally, compared to MACE, quality of life is a subjective measure. There are studies of patient-centered decision-making which show that patient perceptions underestimate the benefits of CABG and overestimate the benefits of PCI. And so patient counseling for what contemporary post-op care looks like for CABG, what are ERAS protocols, and what is the trajectory of recovery would be really important to include in those trials.
I think you raise excellent points. I think, first of all, CABG today is not CABG of yesterday. I mean, improvements happen in all aspects of perioperative care. I tell my patients that they can come off restrictions pretty much right away. I mean, think of orthopedic surgery. You get octogenarians fall down, they get their femur pinned, and then they're up and walking. We put wires there. If you have a secure, good quality sternal closure, I think we could let them go back to activity faster than what we historically thought was appropriate. I don't want to be too aggressive, but we all know that ERAS has really evolved over the years, and that we should be more liberal in our approach without hurting our patients. So that's one thing. The other thing is that I agree, quality of life it's not a new concept, but when we want to apply it to CABG and the outcomes of CABG, we really have to do this in a thoughtful way and in a validated methodology. Maybe some metrics are more appropriate to measure than others for CABG as opposed to other surgical procedures or interventions. So that's something that we need to keep in mind. Any thoughts from the group about that aspect of things?
Yeah, I have something to add and say. I think we need to abound using non-validated endpoints in the clinical trials. And I think that the ischemia trial is just repeating mistake from Excel trial and using a little bit higher threshold, enzymatic threshold for definition of periprocedural MI, which was never validated. So it's a 15 times upper reference limit. And if we see and compare those patients who experience this kind of periprocedural myocardial infarction, they are not either at high risk of spontaneous myocardial infarction or death in comparison with those who did not experience periprocedural myocardial infarction. And I did one exercise. It's just a basic clinical epidemiology, excluding periprocedural myocardial infarction from this CABG patient, and then we are coming to relative risk of 0.7, completely different primary outcome, and probably the recommendation will be completely different than they are right now. Even if we conduct the sensitivity analysis and use 3% periprocedural myocardial infarction like it was published in Freedom and the Syntax trial, then again we have relative risk of 0.75. Again, early invasive is superior to early conservative treatments. It's a completely different primary outcome. So I think we must, for all the time, abound using non-validated definitions in the clinical trials because they are decision makers tomorrow. And we have changed our practice and switched to completely different philosophy based on a non-validated definitions.
I love that, and we should look at timeframes because if I have coronary disease with bad angina and I want to attend the wedding of a friend of mine, I'll have a stent. But if I want to live a long time and I don't have an urgency to get better right away, I'll choose a CABG. So CABG is more weighted towards long-term outcomes, lifelong therapy. PCI is more of an acute, certainly acute coronary syndrome, and if the benefit that we want to derive is immediate. Joe or Patrick, any comments regarding that point?
Maybe just, I agree completely with what you have said. What I would just add to that is look at the FAME-3 trial, which is a very contemporary multivessel disease PCI versus CABG trial. Yeah. The risk of PCI is not lower than CABG. Yes, you take more time to recover in terms of quality of life, yes, of course. But in terms of the raw risk of the procedure, at 1 year, our mortality in CABG is actually lower than PCI. So the impression of a procedure being less invasive, yes, being less risky, yes, is actually a fake, yes, a false impression.
I love that. I'm glad you raised that point because I remember the numbers. It was a 3 in 1,000 perioperative or 30-day mortality for CABG, which was identical to that of PCI. And at 1 year, it was 0.9% for CABG. And if I remember correctly, it was 1.5 or 1.6%. It wasn't statistically significant, but numerically, it was higher in PCI. So it's a fallacy to say that CABG in this modern era is dangerous or unsafe or not tolerated. One other thing that's quickly I want to raise is, in Syntax, they had a registry. And in that registry, 60% were able to be actually enrolled in the trial and 40% went to the registry. Out of that 40%, 35% went into the CABG registry because they could not be PCI'd for anatomic reasons. Only 5% of that whole pie went into the PCI registry because they couldn't be CABG. So that tells you that it's very rare that there'll be a patient who's really sick or really frail with multivessel disease that wouldn't qualify for CABG. And the outcomes for the PCI registry actually were not that good. So I think that needs to be kept in mind. I want to kind of try and bring this to an end by just asking Joe and other members of the panel quick questions. Joe, what piece of advice do you give our membership when it comes to interpreting the evidence?
So I think as we've been talking today, know the details. It's important not just to read what's on Twitter or Instagram or what you're reading on the internet, or just to read the final sentence in the abstract, which is the conclusion. You need to read the study. You need to know the details. You need to understand the patient population. Is this population representative of the people that we treat, or is it really a super select group, which often happens in randomized trials? Know the endpoints, know the inclusion, exclusion criteria, and then interpret the results yourself. I mean, we've been talking a lot about FAME3 today, and as you know, that was a non-inferiority study. But when you look at MACE in FAME3, the confidence intervals don't cross 1, which tells you that CABG from a MACE point of view was superior. Now, I've read that paper several times. There is not one line in that paper that says CABG was superior at 1 year, but it is.
It is.
And the argument that I've been told, well, that wasn't in the protocol. But when you read it, you know CABG is superior when it comes to MACE at 1 year. So I think it's our responsibility to not just listen to what other people are saying or just read the conclusion, but really understand the study, understand the population, understand the details of the inclusion, exclusion criteria, understand the endpoints, understand the definition of the endpoints, as I think we've learned a lot and have talked about today. You know, we have to be responsible.
I mean, you got to look at the protocol and see if they stuck to the protocol, look at the definitions, see if they stuck to them. And then you're right, it was not non-inferior. I mean, double negative is positive, so that's superior, that's better. But nowhere did they say CABG was better.
Well, you can be not non-inferior and not be superior, but in this case, you were superior because when you look at the confidence intervals.
You look at the confidence interval. I think that's a key teaching point. Patrick, you know, I mean, I needed help because I'm not an expert. I'm not a statistician. I'm not a trialist. I'm not a methodologist. So how can the associations, our professional associations, help us, you know, understand and interpret all the evidence in the guidelines when there's controversy like this?
That's a really tough question. I mean, Joe just said very well that you have to read the trials in details, know all of the details of the outcome measures if they follow the protocol. That takes a lot of time. And actually, if you look at it, most surgeons, most people read the abstract. And so if people are reading just the conclusions, they're not getting the essence of a trial. And that's where these webinars, the annual meetings, all of the education that we're doing is so important that we need to get out the message of how do you actually interpret these different trials. And I think that that's organizing these sessions at our annual meetings of our 3 associations is extremely important, because that's where we can tease out, have experts say, well, this is how we've read the data and this is our interpretation. Everybody can then, if they don't agree with it, they can always go back to the trial and look at it in more detail. But to have these debates, have more information be spread out, that's extremely important. Now, I don't have any empirical data to say that that's actually effective. We know that it takes a tremendously long time, 17 years from an idea to go through all of the trialing to actually get into clinical practice and applied.
Yeah.
Takes 17 years.
I've read that.
And that's the best case scenario.
Mm-hmm.
So we've got our work cut out, I think.
Yeah, I think so. I think our associations are a great resource, and I'm very grateful to the AATS and the Dr. Alec Patterson and the editors of the seminars, because I think they kindly agreed to publish a transcript of this roundtable, and that way it'll be available hopefully to a wider audience, because not everybody goes online and use it as a resource. So I'm glad it's going to be hopefully in print. Talking about dissemination, implementation, and staying relevant, I want to ask Milan, how could we update the guidelines? I mean, 17 years is a long time. But that's for implementation and cooperation and guidelines. Let's focus into getting them into guidelines. How could the guidelines be nimble and stay up to date and relevant? What can we do to make sure that that's the case?
So we have a process, and that's the first step, I think, and the most important step. Of course, once when we establish the task force for any guideline, then this task force can be responsible for any updates during the terms of the guideline, which is usually 4 to 5 years. So in light of some new findings or the new evidence, although the most of the time we know all the trials that are coming, so we can plan our timelines according to them. But these people can easily update the recommendation based on the new evidence and submit the document for press in a month of time. So it's important to have the right people for the right topics, and having the expert in the field, and then they can really quickly update all the recommendations.
Well, I think I'm gonna ask the last question before we wrap up to Don. You know, talking about staying up to date, we got to stay up to date with technology, right? So everybody's talking about AI. It's a hot topic. How could AI help us in terms of evidence and guidelines?
That's a great question, and probably an evolving answer. I think AI or any sort of automation can help with, very laborious tasks, such as screening abstracts and maybe summarizing existing evidence. But I don't think that, I think it would be very risky to say that it could be more involved in the process, because a lot of the things we've been talking about, judgment, knowing the details, having a process, harmonization, AI is not free of bias. And, as you mentioned, these studies that are not high quality evidence that go into systematic reviews and meta-analyses and ultimately the guidelines, that's error that gets magnified. And I think there's a risk that with AI, if you don't understand how AI works, that can be baked into that, and the outcome can be just as, catastrophic.
I think that's an excellent take on AI, because I share your opinion. Any other comments from the panel members?
I would be much more positive, actually. These large language models, ChatGPT and so on, have progressed tremendously, gotten to the point that we can now abstract a lot of our medical records to start to populate databases automatically. And that is, the growth there is exponential. Yes, it's not perfect. There are biases. But we also have some empirical data that's being presented at looking at heart team discussions. If you take the whole medical file of a patient, actually having it go through a large language model is more reliable on the outcome of what the recommendation will be than a human discussion. So I think this will be something that will augment what we do, automate it, perhaps. We're not there yet, but definitely a lot of research that should be done there.
Sure. I think it should be supplementary instead of a replacement. But yes.
Yeah. No, I also wonder if we can get, at the patient level with AI and machine learning, and really bring in everything that we know about the patients, and then see how does a patient do who has multivessel disease, diabetes, with this lesion set, and has PCI versus CABG, and we've got 10,000 of them or 100,000 of them, and compare that to the 100,000 in CABG, and how do they do over time? So I'm just wondering, can we even use it as a replacement for trials? I mean, obviously there's bias in decision making that's made along the way, but can it be so good that it's better than propensity matching, all the other statistical tests that we do?
That is fascinating, actually. When we were presenting earlier today about the harmonization of the guidelines, we were asked to say, hey, what the future could be like. And we said the guidelines are the average treatment for the average patient. We want to move to a specific treatment for that specific patient. So it could help us in research and hopefully then translate to more patient-centric or personalized recommendations. Any other comments from the panel members?
Yeah, I just want to take the opportunity once again to thank AATS for this initiative to harmonize our methodology for clinical practice guidelines, and especially Dr. Colson, who has initiated this last year, and we have quickly delivered it.
Yeah, it's a long list of people that we don't have time to thank, but we'll acknowledge in the manuscript. But I want to take this opportunity to thank the panel members. Thank you, Joe. Thank you, Patrick, Don, Milan. I really appreciate it. I hope that our viewers and hopefully readers will have enjoyed it as much as I did and learn from it. I think the summary is we got to trust but verify. Our associations are here, professional associations are here to help us navigate through evidence and guidelines, especially when there's controversy. I'm confident that our specialty will lead the way in setting the bar high and to help us make the best decisions to take the best care of our patients. Thank you very much. Thank you.